For the next section in our program, I'm pleased to welcome my dear friend and colleague, Dr. Anju Noria, who's the Director of Cardio-Oncology in the Advanced Heart Disease section in the Cardiovascular Division and a heart failure specialist, and also Assistant Professor of Medicine at Harvard Medical School. And she'll be walking us through a big topic, which is the management of patients with congestive heart failure. So Anju, I'll hand it to you.
Thanks, Akshay. Welcome, everyone. These are my disclosures. So over the next 40 minutes or so, I'm going to briefly discuss the pathogenesis and prevalence of heart failure. I'll talk for the bulk of the talk about evidence-based therapies for patients with heart failure and reduced ejection fraction. And then I will briefly provide a management approach to patients with heart failure with preserved ejection fraction. So as you know, many different etiologies can lead to left ventricular dysfunction, and this in turn leads to a decrease in cardiac output. The body responds to this by activating neurohormones, including the sympathetic nervous system, the renin-angiotensin-aldosterone axis, and the arginine-vasopressin system. These lead to vasoconstriction in an attempt to restore mean arterial pressure and cerebral perfusion. They also act at the level of the kidney to cause sodium and water retention to try and increase circulating blood volume. And while these responses are adaptive in the short run, in the long run, the vasoconstriction leads to decreased skeletal blood flow and exertional fatigue. The sodium and fluid retention leads to pulmonary edema and shortness of breath. And if you have unabated neurohormonal activation, you ultimately get cardiac remodeling that ultimately leads to progressive LV dysfunction and death. If you look at autopsy specimens of patients with heart failure, this here in the middle is a normal heart. You can see the LV and the RV. In patients with heart failure with reduced ejection fraction, you have eccentric remodeling over time where myofibrils are laid in series. You get LV cavity dilatation. You may or may not get wall thinning, and you have an increase in the volume to mass ratio. In patients with heart failure with preserved ejection fraction, you get concentric remodeling in response to increased wall stress or afterload. You have myofibrils that are formed in parallel. You get thickening of the ventricular wall. You may get a small cavity size leading to a decreased stroke volume, and you get, in general, a decreased volume to mass ratio. If we look at the number of patients who are hospitalized with heart failure in the US, you can see that about 35%, shown here in blue, have heart failure with reduced ejection fraction or an ejection fraction less than 40%. About half of the patients have heart failure with preserved ejection fraction, shown here in green. This is in EF of greater than 50%. And then about 10 to 15% have heart failure with borderline ejection fraction, which is an EF between 40 and 50%. In general, patients with heart failure with preserved ejection fraction tend to be older, are more likely to be female, and have many more comorbidities such as hypertension, chronic kidney disease, and atrial fibrillation. Interestingly, the incidence of coronary artery disease is higher in patients with heart failure with reduced ejection fraction than in patients with heart failure with preserved ejection fraction. If we then look at hospitalizations based on the type of heart failure you have, you can see that technically overall mortality is higher in patients with heart failure with reduced ejection fraction. However, even though this is statistically significantly higher, in absolute terms, heart failure with preserved ejection fraction has almost an equivalent mortality. All-cause rehospitalizations, on the other hand, are much higher in patients with HFpEF than in those with HFrEF, shown here in the red. And this is because they tend to have more non-cardiac admissions, whereas patients with heart failure with reduced ejection fraction tend to have more cardiac or heart failure-related admissions. So moving on to how we as advanced heart disease cardiologists think about heart failure, the ACC and the AHA classify heart failure into 4 stages. And as you move from stage A to D, you have progressive disease. Stage A are those patients who have risk factors for the development of heart failure, but don't yet have structural heart disease. Stage B are those patients who either have reduced ejection fraction or left ventricular hypertrophy, but have never had symptoms of heart failure. Stage C are those patients who have structural heart disease and either currently or previously have had symptoms of heart failure. And stage D are those patients who have refractory symptoms despite the best medical therapy and are patients that are being considered for advanced therapies such as ventricular assist devices or transplant. When we think about symptoms in patients with heart failure, we think about them in terms of the New York Heart Association class. Class 1 are those patients who have no limitations. Class 2 are those who have mild limitations. Class 3 are those who have moderate limitations. And then class 4 are those patients who have difficulty performing activities of daily living or have symptoms at rest. By definition, patients with stage B disease are in NYHA class 1 because they have no symptoms. Patients with stage C can oscillate between classes 1, 2, and 3, depending on how compensated or decompensated they are. And then patients with stage D tend to be in NYHA class 3B or 4 in terms of their symptoms. So when we think about therapies for heart failure, we really think in terms of the stages of heart failure. So stage A are those patients where you're trying to control risk factors to prevent them from developing heart failure. The guidelines currently state that you should try to control blood pressure to a target of less than 130/80. And this target is largely derived from the SPRINT trial, where they showed that patients whose blood pressure was controlled to less than 120/80 had fewer future heart failure hospitalizations compared to those patients whose blood pressure was controlled to a target of less than 140/90. Therefore, we've split the difference, and currently the target is less than 130/80. You want to treat lipid disorders in accordance with the guidelines based on the patient's estimated risk or on the presence of atherosclerosis or diabetes. You want to control metabolic syndrome and diabetes, and there have been 3 large trials recently looking at SGLT2 inhibitors in patients with diabetes and high risk for cardiac disease. And in all of these patients, it was shown that SGLT2 inhibitors, namely empagliflozin, canagliflozin, and dapagliflozin, reduce the development of new heart failure. Additionally, you want to encourage smoking cessation and regular exercise, at least 150 minutes per week. And in the appropriate patient population, such as those with diabetes and microalbuminuria or those with vascular disease, you want to place them on an ACE inhibitor or an angiotensin receptor blocker. And lastly, you want to discourage the use of toxins that lead to cardiomyopathy. Recently, there has also been a trial called the STOP-HF trial, which shows that in patients who are at high risk for cardiovascular disease, you can check a BNP, and if the BNP is greater than 50, these may be patients who are at risk for developing heart failure in the future and can be considered for referral to a cardiovascular specialist to reduce this risk. In stage B heart failure, we're really looking to identify and treat any reversible causes of left ventricular dysfunction, such as in patients with CAD, you may want to revascularize them. In patients with valvular heart disease, you may want to correct the lesion. You want to prevent progressive left ventricular remodeling, and you want to delay the onset of symptoms. In cases of asymptomatic left ventricular hypertrophy, you want to have aggressive blood pressure control by using a thiazide, a calcium channel blocker, or a RAS inhibitor. In patients with asymptomatic LV systolic dysfunction, both ACE inhibitors and beta blockers have been shown to improve mortality and prevent or delay the development of symptoms. And in patients with post-MI LV dysfunction and diabetes, aldosterone antagonists have also been shown to improve outcomes even in asymptomatic patients. So I'd like to move on with a case. This is a 39-year-old African-American gentleman with type 2 diabetes and hyperlipidemia who presents with an acute anterior wall MI. He undergoes urgent angioplasty and stent placement to the LAD. His post-MI echo shows an ejection fraction of 30 to 35% with anterior akinesis. He has no symptoms of heart failure. His exam is notable for being tachycardic with a blood pressure of 105/73. He's saturating 100% on room air. He has no jugular venous distension. His lungs are clear. He has no murmurs and no edema. His labs are notable for a mildly elevated creatinine of 1.2, a hemoglobin A1C of 7.1, and a normal lipid profile. Which of the following medications would you not recommend for this patient? A, losartan, B, metoprolol succinate, C, spironolactone, or D, furosemide? Please go ahead and vote. Okay, so I think we have a quorum. We have more than 120 votes in. So at this point, most of you have the correct answer, which is furosemide. So this is a patient with diabetes and a post-MI EF of 30 to 35% and no symptoms of heart failure. So this is a patient with stage B heart failure. And as I mentioned before, both RAS blockade and metoprolol succinate have been shown to prevent progressive remodeling, improve mortality, and reduce the onset of symptoms in patients with stage B heart failure. Because this is a patient with diabetes and post-MI LV dysfunction, even though he is completely asymptomatic, spironolactone has been shown to improve mortality in these patients. You would not give furosemide to an asymptomatic patient with no evidence of volume overload, since furosemide is primarily to treat symptoms, but not really meant to improve mortality in this patient population. So moving on to goals of therapy for symptomatic heart failure or stage C heart failure. In general, when a patient presents with symptomatic heart failure, you want to address any precipitating factors. You want to identify and treat the causative or inciting factor, whether it be medication noncompliance, new ischemia, arrhythmia, pneumonia, or something else that has destabilized them. You want to initiate treatments to prevent disease progression and mortality. In general, this includes neurohormonal blockade, and you want to manage related risks such as sudden cardiac death. You want to improve symptoms and end organ perfusion, and you do this by lowering the pulmonary capillary wedge pressure with diuretics. And in certain patients, you want to optimize cardiac output to maintain adequate end organ perfusion. And you want to reduce the length of stay and prevent rehospitalization. And this is largely done through patient education. And if available, you want to introduce them to a longitudinal disease management program where they can be followed closely to try and prevent them from coming back into the hospital. Just to review, you know that there have been many trials looking at ACE inhibitors in heart failure. These have varied from patients with no symptoms, such as the SOLVE prevention trial, to patients with severe symptoms, such as the consensus trial. In all of these trials, ACE inhibitors were shown to improve mortality in patients with heart failure. Similarly, angiotensin receptor blockers have also been looked at in patients with symptomatic heart failure, either as alternatives to ACE inhibitors, primarily in patients who either have a cough or angioedema in response to an ACE inhibitor, or in some trials in addition to ACE inhibitors to see if additional RAS blockade offered a greater mortality benefit. In general, if they're used as alternatives, there appears to be no significant difference in the mortality benefits between ACE inhibitors and angiotensin receptor blockers. In general, angiotensin receptor blockers are better tolerated from a side effect profile. When you give them in addition to ACE inhibitors, there does not appear to be any additional mortality benefit. There may be an improvement in heart failure hospitalizations. However, there is a significant increase in side effects, namely hyperkalemia, hypotension, and worsening renal function. So in general, we do not recommend adding an angiotensin receptor blocker to an ACE inhibitor. However, you can use it interchangeably with an ACE inhibitor or in patients who are intolerant to ACE inhibitors. Beta blockers have also been shown to have a mortality benefit in patients with heart failure, especially if used at high doses. Unlike ACE inhibitors and angiotensin receptor blockers, this is not a class effect. In fact, the BEST trial, which looked at the beta blocker bucindolol, did not show a mortality benefit in patients with heart failure. Therefore, you should use one of the approved or proven beta blockers, namely bisoprolol, metoprolol succinate, or carvedilol in patients with heart failure to improve their outcomes. The next series of drugs that have been trialed are the aldosterone antagonists. There have been 3 large trials looking at minimally symptomatic to highly symptomatic patients. And all of these looked at aldosterone antagonists on top of ACE inhibitors and beta blockers, and they showed that they offered an additional mortality benefit. However, you have to be careful about monitoring potassium and renal function in patients that you start on an aldosterone antagonist. The new kid on the block has been sacubitril valsartan, also known as an angiotensin receptor blocker neprilysin inhibitor. This is a combination drug that contains the angiotensin receptor blocker valsartan that blocks angiotensin at the AT1 receptor, thus inhibiting renin-angiotensin aldosterone activation. You also have sacubitril, which is a neprilysin inhibitor, and this prevents the breakdown of vasodilatory natriuretic peptides such as ANP, BNP, and CNP. It also increases adrenomedulin, substance P, bradykinin, all neurohormones that are beneficial in heart failure. The Paradigm trial compared sacubitril valsartan to enalapril in patients with symptomatic heart failure and an EF of less than 35%. And what it showed was that sacubitril valsartan had an advantage over enalapril, both in terms of cardiovascular death and in terms of heart failure hospitalizations. Interestingly, sacubitril valsartan did have a greater incidence of symptomatic hypotension compared to enalapril. And this is because not only are you causing vasodilation by inhibiting the RAS axis, but you're also increasing vasodilatory peptides in these patients. It caused less renal dysfunction, and there was no increase in the incidence of hyperkalemia, angioedema, or cough in these patients. Based on this trial, there was a guideline update in 2016, which basically said that any patient with chronic heart failure with reduced ejection fraction should be on an ACE inhibitor or an angiotensin receptor blocker or an ARNI in conjunction with beta blockers and mineralocorticoid receptor antagonists. In patients with chronic symptomatic heart failure who can tolerate an ACE or an ARB, you should consider replacing it with an ARNI to further reduce their morbidity and mortality. However, there are certain points that should be kept in mind when you start someone on an ARNI. If they are on an ACE inhibitor, you have to make sure that they are completely off the ACE inhibitor for at least 36 hours before starting the ARNI. And the reason for this is that ACE inhibitors increase bradykinin levels, as do the ARNIs. So if you overlap them, you increase your risk of angioedema significantly. So you have to allow the ACE inhibitor to wash out before you introduce the ARNI. If a person is on a low dose of an ACE inhibitor or an ARB, or they have borderline blood pressure, or they have a low eGFR, or they've never been on any of these medications, you want to be very careful and you want to start at the lowest dose of sacubitril valsartan, which is 24/26 twice daily. You want to monitor the blood pressure, the potassium, and the creatinine after the dose has been in their system for 1 to 2 weeks. And then you want to increase it further in a stepwise fashion. And ultimately, you want to try to get the patient on the maximum tolerated dose, since that has the maximum mortality benefit. There are many patients who cannot tolerate an ACE inhibitor, an angiotensin receptor blocker, or an ARNI, either because of renal dysfunction or hyperkalemia. In these patients, you should consider the combination of hydralazine and Iserdil. This was first studied in the VHEFT-1 trial, which compared hydralazine Iserdil to placebo. And as you can see here in the yellow lines, hydralazine Iserdil had a significant mortality benefit compared to placebo in patients with heart failure with reduced ejection fraction. However, after the SOLVED and consensus trials came out, VF2 looked at hydralazine and Iserdil compared to enalapril, and enalapril had a greater mortality benefit than hydralazine Iserdil. Therefore, we moved on to using ACE inhibitors as first-line therapy and reserving hydralazine and Iserdil for those patients who cannot tolerate an ACE inhibitor, an ARB, or an ARNI to try and improve morbidity and mortality. People who conducted the VHEF trial had an interesting observation that somehow African-American patients appeared to do better with hydralazine Iserdil than with the ACE inhibitor. However, it was felt to be unethical to do a head-to-head comparison of Iserdil and hydralazine with an ACE inhibitor in African-American patients. Therefore, the AHEFT trial was conducted where they looked at adding hydralazine and Iserdil to background therapy of ACE inhibitors, beta blockers, and spironolactone in patients who declared themselves as being African-American. And what they found was that the combination of Iserdil and hydralazine actually further improved mortality in these patients. So if you have an African-American patient, such as our patient, who has adequate blood pressure room to tolerate additional medications after being on maximally tolerated doses of an ACE or an ARB, beta blocker, and spironolactone, you should consider adding Iserdil and hydralazine to their medical regimen. Digoxin is a very old drug that has been used for many years in heart failure. The first trial looking at digoxin was the Radiance trial. Here, they took people on digoxin and withdrew half of them from digoxin therapy, and the other half were maintained on digoxin. And as you can see, the patients who were withdrawn had a significantly higher rate of heart failure hospitalizations compared to those who were maintained on digoxin. Subsequently, the DIG trial was conducted, which was a randomized clinical trial of digoxin versus placebo in patients with symptomatic heart failure. And as you can see here, there was no mortality benefit with digoxin. Furthermore, digoxin has a very narrow therapeutic window, and levels greater than 1 have been found to be toxic and harmful in patients with heart failure. So in general, we don't use digoxin routinely, but reserve it for those patients who either have heart failure and AFib with difficult to control rates, or in patients who have recurrent hospitalizations and limited other options for medical therapy. Heart rate has been another new goal that has been identified, or a new target for therapy that has been identified in patients with heart failure. It has been shown that the higher your resting heart rate, the greater your mortality in patients with heart failure. Ivabradine is a selective inhibitor of the funny channel in the SA node of the heart. It binds to this channel when it is open and delays the slope of depolarization, thereby reducing heart rate without having any effect on myocardial contractility or blood pressure. And it is a use-dependent block, meaning the lower the heart rate, the less the drug binds, and therefore it has an automatic control in terms of causing symptomatic bradycardia. The SHIFT trial looked at ivabradine in addition to guideline-directed medical therapy in patients with symptomatic heart failure and an EF of less than 35%. All of these patients had a resting heart rate greater than 70 and were in sinus rhythm at the time of initiation of ivabradine. And what they found was that ivabradine, shown here in the blue, reduced heart failure hospitalizations compared to placebo, but did not have any significant impact on mortality. Based on this, there was another guideline update that if you have a patient who remains symptomatic despite maximally tolerated guideline-directed medical therapy, is in sinus rhythm, and has a heart rate greater than 70, you can consider adding ivabradine to reduce heart failure symptoms. In general, if a patient has a high heart rate, you should make sure that their beta blocker has been maximized, since that has a mortality benefit. If they're less than 75, you want to start at an ivabradine dose of 5 milligrams twice daily. If they're greater than 75, you start at a lower dose of 2.5 BID. If their heart rate 2 weeks later is greater than 60, you can increase to 7.5 BID. If the heart rate is between 50 and 60, you continue 5 BID. And if the heart rate is less than 50 or they develop symptomatic bradycardia, you can either decrease the dose or stop the drug entirely. Iron is another important new target in heart failure. About 50% of heart failure patients have iron deficiency with or without anemia, and iron deficiency has been associated with increased mortality in patients with heart failure. People have looked at erythropoietin-stimulating agents, and these have not shown an improved outcome in patients with heart failure. Oral iron is very poorly absorbed and therefore also does not improve functional capacity or quality of life in patients with heart failure. However, there have been several trials looking at IV iron given here as ferric carboxymaltose. And as you can see here in deep purple or blue, the ferric carboxymaltose improved 6-minute walk distance compared to placebo, and also reduced heart failure hospitalizations compared to placebo. So based on this, there was another guideline update that in patients with symptomatic heart failure, you should check iron studies. If their ferritin is less than 100, or they have a percent saturation less than 20 with a ferritin between 100 and 300, you should consider giving them IV iron to improve their functional status and their quality of life. Erythropoietin-stimulating agents should not be used in this patient population. So going back to our case, the patient presented 2 years later to the ED with palpitations and shortness of breath. He was on a good regimen consisting of losartan, metoprolol succinate, aspirin, atorvastatin, metformin, and liraglutide. His exam showed that he was tachycardic. He had a marginal blood pressure. He had evidence of volume overload as seen with an elevated JVP, bibasilar crackles, but he had no edema. He had an irregularly irregular pulse, and his EKG showed AFib with a rapid ventricular response. His labs were notable for mild worsening of his creatinine to 1.4. Can you advance my slide? What would be the next best step in his management? A, add digoxin. B, add ivabradine. C, change metoprolol succinate to carvedilol. Or D, emergent electrical cardioversion. Okay, so I think we have a fair number of responses at this point. Unfortunately, most people did not get this one right. So the correct answer is add digoxin. The reason you would not give ivabradine to this patient is that he is an AFib, and ivabradine acts on the funny channel in the SA node. So you have to be in sinus rhythm in order for ivabradine to have an effect on this patient. His blood pressure is marginal, so you would not change him from metoprolol succinate to carvedilol because that is more vasodilating. And he's not hemodynamically unstable to the point where he needs emergent electrical cardioversion at this point.
Click with your mouse.
Sorry. Before I depart from approved therapies for heart failure with reduced ejection fraction, I just want to alert you to two new drugs that have come on the horizon. The DAPA-HF trial was a recent trial that looked at the SGLT2 inhibitor dapagliflozin in patients with heart failure with reduced ejection fraction, either with or without diabetes. As I mentioned before, several trials in patients with diabetes and high risk for cardiovascular disease showed that dapagliflozin and other members of the drug class reduce incident heart failure hospitalizations. Therefore, it led to the hypothesis that perhaps dapagliflozin would be beneficial in heart failure with reduced ejection fraction, even in patients who did not have diabetes. And as you can see here, dapagliflozin compared to placebo reduced the incidence of cardiovascular death or heart failure hospitalizations in these patients. This drug is currently approved by the FDA for patients with heart failure with reduced ejection fraction, regardless of diabetes, but has not yet been approved by CMS for this indication. The biggest side effects are hypovolemia because it promotes glucoseuria, so you get an osmotic drag of fluid out of the body. You can get an increased risk of UTIs, particularly fungal UTIs. You can get balanitis, and you can get DKA. Another drug that has been recently studied is vericiguat. Vericiguat is a soluble guanylate cyclase stimulator and sensitizer. This is a drug that is commonly used to treat patients with pulmonary hypertension. And in patients with severe symptomatic heart failure, vericiguat was shown to reduce heart failure hospitalizations, but did not impact cardiovascular death. This drug has not yet been approved, but we remain to be seen how this fits into the armamentarium of drugs for systolic heart failure. The major side effects are hypotension, and you can get anemia for unknown etiology in these patients. Heart failure management, as you know, is more than drugs. You have to counsel your patients about sodium and water restriction. You have to educate them about weighing themselves and taking their medications. You want to encourage aerobic activity. You want to make sure they take their medications. There are non-pharmacologic therapies such as cardiac resynchronization therapy and treatment of obstructive sleep apnea. And you want to manage related risks such as sudden cardiac death, thromboembolism, and stroke. CRT in general has been shown to improve morbidity and mortality in patients with an EF less than 35% who are in sinus rhythm, have a QRS duration greater than 120 milliseconds, and have symptoms despite guideline-directed medical therapy. In general, if you have a left bundle or a QRS duration greater than 150 milliseconds, you derive the maximum benefit from CRT. CRT is best indicated in those patients who have a left bundle and a QRS greater than 150. It has a moderate indication in those who have a QRS between 120 and 150. If you have a non-left bundle, you should have a QRS greater than 150. And in general, you do not want to use it in anyone with a non-left bundle and a QRS less than 150. Similarly, ICDs have been shown to improve mortality in patients who have had a cardiac arrest or sustained VT. As primary prevention therapy, they're indicated in people with an EF less than 35% who are 3 months out from revascularization or have been on guideline-directed medical therapy for at least 6 months and continue to have an EF less than 35%. They are not indicated in patients with end-stage heart failure unless they're being bridged to advanced therapies. There have been 2 large trials looking at warfarin and low-dose rivaroxaban to prevent embolic strokes in patients with low EF and normal sinus rhythm. Neither have shown a benefit, and therefore routine anticoagulation in the absence of AFib or LV thrombus is not indicated in patients with heart failure. So going back to our case, our patient did well for about a year, and then he came back for a routine clinic evaluation. At this point, he said he was dyspneic after climbing one flight of stairs, but was otherwise asymptomatic. He was on a good medical regimen. His exam showed a heart rate of 70, a blood pressure of 120/80. He had no evidence of volume overload on exam. His labs were stable, and his EKG showed sinus rhythm at a rate of 70, a left bundle, and a QRS duration of 120 milliseconds. What would be the next best step in his management? A, upgrade of the ICD to a CRTD device. B, add hydralazine and Isodil. C, stop losartan and start sacubitril valsartan. Or D, start furosemide. Please go ahead and vote. Okay, so we have about 100 votes in, and most of you got this right. The correct answer is C, stop losartan and start sacubitril valsartan. A and B are not completely wrong, but they're not the best answer. You could upgrade his ICD to a CRTD, but his QRS duration is only 120 milliseconds, and so he has a class 2A indication for CRT. He is African American, therefore you could consider adding hydralazine and Isodil, but the guidelines would say that you should first try to switch him to sacubitril valsartan before considering adding hydralazine and Isodil. And again, he is not volume overloaded, so you would not give him furosemide.
Just 5 minutes.
Yeah. He does well again for a few years and then presents with profound weakness and severe dyspnea with minimal exertion. His exam shows tachycardia. He has a very low blood pressure with a very narrow pulse pressure. He's tachypneic and a little bit hypoxic. His exam shows massive volume overload with JVP to the angle of the jaw, bilateral crackles. He is lukewarm to the touch. His labs show end organ dysfunction with an elevated creatinine and elevated LFTs. His NT-proBNP is elevated. He has influenza A, and an echo shows a decline in his EF to 15%, severe mitral regurgitation, and moderate tricuspid regurgitation. In addition to IV diuretics and oxygen, what would you do next for this patient? IV dobutamine, IV milrinone, a pulmonary artery catheter to help you decide if he needs inotropic support, or an intra-aortic balloon pump. Please go ahead and vote. So in the interest of time, I think I'll stop it right here, but most of you are absolutely correct. IV dobutamine would be the best agent. He's clearly in cardiogenic shock, and he has a very low blood pressure, so dobutamine would be safer than milrinone, which is a much more potent inodilator. You could consider a PA line, but it seems pretty clear based on his history what his problem is, and an intra-aortic balloon pump is only needed if he fails any medical therapies. So symptomatic heart failure is really a clinical diagnosis. You ask yourself if the patient is congested and if they have adequate perfusion. You can use BNP as a helpful target if you're not sure whether or not they have heart failure based on your clinical exam. If the patient is wet, adequately perfused, you diurese them with IV diuretics. If they're inadequately perfused, you first warm them up and then you dry them out. If they have an adequate blood pressure, you can use an oral or intravenous vasodilator. If they have a marginal blood pressure, you can use an inotrope. either dopamine or dobutamine, or a more potent inodilator like milrinone. Or if they're cold, you can first warm them up and then you would dry them out. In terms of trials of diuretics, the DOSE trial was the only trial that was published. It took patients who were on diuretics at home and came in with decompensated heart failure and randomized them to low dose or high dose diuretic therapy given either as bolus dosing or as a continuous infusion. And what they found was that high dose diuretics made you lose weight more rapidly, improve dyspnea more rapidly. You had mild worsening of your renal function, but there was no difference in outcomes at 60 days. Interestingly, bolus versus continuous diuretic infusion made no difference. So what this says is that you can use high-dose diuretics without worrying about adverse outcomes in these patients. Inotropes in general increase mortality, and this was seen in the ESCAPE trial, which looked at clinical assessment-guided therapy versus PA-line catheter-guided therapy. And as you can see, there was no difference in outcomes. However, patients who got inotropes, shown here in the solid line, had a much lower survival compared to those who got neither therapy or vasodilators. So in general, you really don't want to reach for inotropes unless it is absolutely necessary. Who should you refer for advanced therapies? Anyone who has escalating diuretic requirements, progressive end organ dysfunction, increasing frequency of hospitalizations, increasing burden of arrhythmias, intolerance to standard medical therapy, refractory symptoms, need for inotropic support, cardiac cachexia, or an objective functional capacity of less than 10 milliliters per kilograms per minute, despite adequate effort on a cardiopulmonary exercise test. Heart failure with preserved ejection fraction is a very heterogeneous clinical syndrome, which is part of the reason why clinical trials of neurohormonal antagonism have not been successful in this patient population. If you look at the guidelines, they all fit on one page, unlike our therapies for HFrEF. In general, you want to control blood pressure. You want to use diuretics cautiously for patients who are volume overloaded. If people have ischemia, you want to revascularize them. If they're in atrial fibrillation, you want to exercise rate control and even consider rhythm control in refractory patients. If someone continues to have symptoms, you can consider using an aldosterone antagonist or an ARB or even an ARNI to try and reduce heart failure hospitalizations. And in general, nitrates and phosphodiesterase inhibitors like sildenafil have not been shown to improve functional capacity or quality of life in these patients. So to summarize, heart failure is a clinical diagnosis. BNP can be a useful adjunct if your diagnosis is uncertain, but it should not replace your clinical assessment. RAS blockade and beta blockers are the cornerstone of heart failure therapy and should be used in all patients at the highest tolerated doses. ARBs should be used if you are ACE intolerant. You should consider substitution with an ARNI in a patient on an ACE or an ARB to improve their mortality and reduce hospitalizations. Beta blockers should be used in these patients, should not be started when they are acutely decompensated. Aldosterone antagonists are the favored second-line drugs after RAS blockade and beta blockade. In patients who are intolerant of ACE or ARB, you should consider giving hydralazine and Iserdil to improve mortality. Digoxin and ivabradine reduce heart failure hospitalizations but have no impact on mortality. Device therapy should be considered in appropriate patients. And unfortunately, heart failure with preserved ejection fraction remains a poorly understood and heterogeneous disorder with limited therapeutic options. Thank you for your attention.
Anju, that was a fantastic coverage of a lot of material. I think we're a little short on time, so if it's okay, I'm going to push the questions, of which there are several, to the Q&A we have at the tail end. If you're able to come back, that's great. Otherwise, we'll try to field them for you. But thanks so much for coming.
Thank you.